I've been asked to talk the last few years and have been unable to, so I'm really excited to be here. I'm always excited to talk about stroke. How many of you in here are nurses? How many are physicians? How many are other personnel, allied health professionals? Oh my goodness, okay, what do you all represent? Social workers?
Dental hygiene.
Dental hygiene, cool. Cool. My husband's a dentist. Yeah. What else?
Physician assistant.
Physician assistant, okay. Who else?
Radiology.
Radiology. What else? Just trying to get a feel for the audience. Okay, great. I'm going to go ahead and talk to you a little bit. I'll have some clinical stuff, some epidemiological stuff, also some clinical trials information for you as well. What I'm really going to focus on today are quality improvement initiatives throughout the United States and especially in Texas. And I'll explain to you a little bit about what we've started here in the way of stroke. How many of you think that stroke is a major public health problem? Good. How many of you think it's going to get worse? Absolutely. Unfortunately, with our aging population, it is going to get worse, and we'll talk about that. Now, I've got a little bit of a problem here with the angle of the slides, so I'm going to move over here. First of all, I want to talk to you all a little bit about stroke epidemiology, just to give you an idea of the magnitude of the problem of stroke in the United States, okay? And then we'll talk very briefly about the problem of stroke in the world. First of all, in the United States, stroke is the third leading cause of death, behind heart disease. Second is all cancers lumped together, and as you know, there are lots of different types of cancer, okay? Approximately 160,000 patients with stroke die each year. It is a leading cause of disability, adult disability, in the United States. And unfortunately, it costs billions of dollars each year to take care of stroke patients. Worldwide, stroke is the #1 cause of death, okay? Each year, approximately 500,000 new strokes occur each year. The other 200,000 are recurrent strokes. Many of those strokes are preventable if we just do the right thing, okay? Not only as clinicians, but also as good stewards of our body. 75% of patients that have strokes are over the age of 65, which makes it obviously really relevant to this conference's scheduled talks. For each decade over the age of 55, your chances of having a stroke doubles. Okay, so if you're starting to enter the golden age of 55, you need to start really thinking about prevention modalities, okay? Especially blood pressure control. African Americans have the highest risk of stroke. They also die more frequently from stroke. So it's very important for us as clinicians to try to make sure we educate our patients. And I'm all over and all about patient education. I think that that's really the gold standard of making sure that we try to impart this information to our patients and that we prevent stroke. Most of the patients I've worked with in my 20-year clinical history of working with stroke patients, most patients dread the thought of having a stroke, obviously. And I would argue that many patients, heart attack's a horrible, horrible thing. If you survive it, many times heart patients can go on to live productive, wonderful lives. If you have a stroke and you're disabled, paralyzed, can't speak, can't swallow, just imagine yourself in that situation, okay? Hispanics also have a very high rate of stroke. We are learning more and more about the Hispanic population. We have only just recently been able to really gather better data Hispanics in population data were lumped into Caucasian, and so it was very difficult to kind of get a feel for exactly what was happening to that particular ethnic group. So now ethnicity is kind of being pulled out a little bit, and we're getting a better handle on the rate of stroke in Hispanics. The cost of stroke used to be about $56 billion annually. New figures are above $60 billion each year. That's a direct and indirect cost. It's very expensive to take care of stroke patients. And in the southeastern United States, that area of, there's about 13 states that were originally called the stroke belt, and then there's actually a group of states within that clump called the stroke buckle that have the highest overall rate of stroke in the United States. Texas is now, especially eastern Texas, is now a part of the stroke belt. Okay? This is just a slide to kind of show you more recent statistics and to prove to you that African Americans have the highest rate of stroke. As you can see, it increases with age. Black men and women have the highest rate of stroke and highest rate of death due to stroke in the United States. Now, these are ischemic strokes. Ischemic strokes are caused because of a blocked blood vessel to the brain. Okay, shutting off blood supply, needed blood, oxygen to the brain. Okay? 85% of all strokes are caused because of blocked blood vessels in the brain. Okay, we're going to talk about how hypertension plays into this in just a minute. Hypertension is the #1 risk factor of stroke. And it's obviously, if somebody knows they have hypertension, hypertension is the #1 preventable cause of stroke. We know that the rate of stroke has declined since the 1950s because of better treatment, recognition, and treatment of high blood pressure. But still, over 50%, probably 60% of Americans have high blood pressure, either don't know it, or choose not to have it treated, or choose not to take their medicines the way they're supposed to. Okay? Again, the #1 preventable cause of stroke. This is the incidence of first ever intracerebral hemorrhage. Now, an intracerebral hemorrhage is a burst blood vessel within the brain. And there are two types of intracerebral hemorrhages. Those caused by a ruptured aneurysm or subarachnoid hemorrhage, and those caused because of what? Hypertension, #1 cause of stroke. Folks with high blood pressure, and it doesn't even, I mean, the higher the blood pressure, the greater risk, but in some patients, especially diabetics, if you already have fragile blood vessels, you have small vessel disease, you have hypertension on top of that, it makes it even worse, okay? The prevalence of silent infarction. Throughout the United States, there are probably a lot of people that have had a stroke, but they don't know it. And in fact, we know that that's true because we can do, we can look at MRI, we can look at neuroimaging, and we can see that maybe anecdotally a patient goes in, they've got a headache. Okay, for some reason they have a headache. Doctor orders a CT scan or maybe an MRI and discovers, lo and behold, that patient's had what's called a silent infarction or a silent stroke. Those little silent strokes can add up over time. If you have enough of those little silent strokes, obviously you may end up with some cognitive deficits, cognitive disabilities. Patients may also have very subtle signs of neurologic deficit, but slightly undetectable, almost subclinical. But yet maybe they can recall, oh, something was a little bit funny. Okay? I'm going to move forward on this one. So residual disability after stroke. This is what kind of the information that you're probably interested in. What happens to these patients after they have a stroke? What's left over? Well, the majority of patients end up with some kind of hemiparesis. Hemiparesis means paralysis on one side of their body usually. Hemi meaning half, paresis meaning paralyzed. Okay? That's a lot of people with the inability to move their arm, move their leg, to walk properly. You can understand why those patients might be taken out of the workforce, unable to be productive, if you will, in society. So that's why I would argue that it is a major public health problem. 30% of those patients were unable to walk without some assistance, okay, meaning a cane, a walker, maybe somebody holding on to their arm. 26% were dependent on family members or other caregivers for their activities of daily living, that is feeding, toileting, dressing, any of those things that we so often take for granted every day because we're able to do it, okay? 19% of those patients had what's called aphasia. Does anybody know what an aphasia is? What's that? I'm hearing. Ah, good point. No. It's the inability, right. That's okay. We're going to get there. We're going to get to definitions. Good. Yep, you're there. Aphasia is you can't talk properly. You can't get your words out properly. That's called a Broca's aphasia. Or you cannot comprehend what's being said to you. That's called a Wernicke's aphasia. Now, can you imagine, we take so for granted, I take for granted the ability for me to be able to get my words out, to talk to you just stream of thought, stream of good fluent speech. Can you imagine not being able to do that? I recently worked with a woman who had a complete left carotid artery occlusion. Wonderful, wonderful woman. Had a Broca's aphasia, severe Broca's aphasia. Why? Because she had a large stroke on the left side of her brain. Left side of the brain has your speech and language center, okay? So very often if a patient has a left hemispheric stroke, they end up with some sort of speech disorder, okay? Whether it's a Broca's or a Wernicke's aphasia. Now, dysphagia, we have dysarthria, which is slurred speech, and usually that's caused because of motor paralysis, say, of the face, maybe numbness of the tongue, something like that. But dysphagia, which is what somebody was thinking about over there, is the difficulty swallowing or inability to swallow. Now, can you imagine, and I've seen patients like this in my clinical practice, they have a stroke in just the right place in the brainstem, and they can't swallow. So they have to have a tube down their nose for feeding, or they end up with what's called a gastrostomy, a tube in their stomach to be fed directly into their stomach, okay? Those are the sequelae of stroke. 35%, and I would argue with you probably more, of patients were depressed after stroke. Now, I would be too. I mean, to me, that's like a no-brainer. You know, if I was unable to do the things that I did before, I would be like totally depressed, okay? Which leads to other major problems. I really encourage, and I was very lucky. You're going to hear from another stroke neurologist this afternoon, Dr. David Sherman. He was my boss for 20 years. Dr. Sherman was just incredible. He was so on to treating patients for depression. If I noted in my practice that a patient seemed depressed, he just had no problems doing that. Many clinicians don't want to deal with depression. So I would really encourage you to, when you're with your stroke patients and they seem depressed, there is help for them, either counseling or antidepressive drugs, okay? Unfortunately, 26% were institutionalized in a nursing home after a stroke, okay? Yeah. What happened? It's not working. Oh, there it goes. Okay, awareness of stroke, risk factors, and symptoms. Unfortunately, about 94%, unfortunately, a lot of patients don't know what the symptoms of stroke are, okay? Which leads to the reason why they don't seek care. Only 94% of patients could not identify that numbness, weakness, face, arm, or leg was a symptom of stroke. Okay? Which means that we are not doing in this series, okay, which means that we're not doing a very good job of educating our patients as to what the symptoms of stroke are. So why don't we talk about the symptoms of stroke? What are the symptoms of stroke? Yell them out. This will be audience participation. Absolutely. Numbness on one side of the body. Doesn't usually just include the face. Okay, it usually includes the face, arm, leg, or just arm, leg. Okay, that's called a pure sensory stroke, and it's very common in patients that have what are called lacunar infarctions. Okay, small subcortical strokes. Okay, what other symptoms of stroke? Incoherency, confusion can be. If you had a stroke all of a sudden, and this came on suddenly, and you didn't know what was happening, would you feel a little disoriented, a little off balance? You would not feel totally in control of what was going on. So absolutely, patients can, what I've seen in my practice is that patients cannot say to you, well, I have a dysarthria and I have right hemiparalysis. They can't do that, they don't articulate. What they say is, I feel funny, or it felt ugly. I hear that very frequently. Or they can't give it the medical terms that we give it. Okay, so be sure to listen to them in your practice. What are the other symptoms of stroke? Loss of what? Loss of motor function, exactly. Kind of textbook, loss of motor function. Suddenly I'm standing up here and I have this sudden inability to speak, and I develop right hemiparalysis, as we talked about before. My arm goes weak, I drop this, and I fall to the right side. Okay? Very, very common symptom of stroke, which leads to, or can lead to, the inability to walk properly. You know, you're off balance, or you feel like you're veering to the right, kind of thing. Okay, what else? Vision. Visual problems, visual disturbances. Patients with an occipital lobe stroke in the back of their brain, in the occipital lobe, can have what's called a field cut. They can't describe it because it's bizarre, let me tell you. It's where they lose half of their visual field. So they can't see, for instance, if I have a right occipital lobe stroke, then I won't be able to see my peripheral vision. I'll have a field cut here, like there's just a black thing. I can't see on this side my nasal visual field here, or the temporal over here, so I have no peripheral vision over here. Okay, now can you imagine you're a layperson and you're trying to describe that to somebody? I mean, I'm having trouble describing it to you. Okay, the other thing that can happen, and this is common, it's a common symptom of transient ischemic attack. You've heard of that. We're going to talk about TIA. And that is like a curtain coming over the visual field for a very short amount of time. It used to be called amaurosis fugax, and now they've changed it to transient monocular visual loss, TMB, transient monocular blindness. Okay, so absolutely you can have visual loss. Headache. Headache is common. Headache's very, very common in a patient that has an intracerebral hemorrhage, because all of a sudden you've got blood spilling into brain tissue, compressing nerve cells. Headache is one of the very few pain symptoms that the brain feels. Many patients with an ischemic stroke may not have headache. So headache is not always a prodrome to stroke. If it's a severe headache, it's very likely. You know, it could either be a subarachnoid hemorrhage or it could be an intracranial hemorrhage of some kind. Okay? What else? What else could be a symptom of stroke? Visual-wise.
Slurred speech.
Slurred speech, absolutely. Yes, you can have speech problems. Yep. Visually, you can also have double vision. Patients can have double vision, one on top of the other or side by side. Now that will drive patients nuts. Can you imagine having double vision all the time? I mean, I can't. Okay, very good, guys. All right, TIA is a very potent risk factor for stroke. And when I looked at these statistics, I pulled these off of the CDC, American Heart Association website. These are some of the best statistics that we have in population studies. TIA is an incredibly important, potent risk factor for stroke. Many patients have a TIA, but they ignore it. They're so happy when all of a sudden the feeling comes back in their right or left side, or they can move their arm again, that they ignore it. But that, I mean, as you can see by these statistics, many patients, go on to have a stroke.
Can I ask you something?
Yes.
When you were talking about the different symptoms,
Yes.
How long, like the shortest period of time to the longest period of time, if somebody had something?
Excellent.
Okay.
Excellent question. Okay, let's talk about stroke definitions of time, okay? I think that's what you're looking for.
Right.
A stroke definition, by definition, is a focal, non-convulsive, neurologic deficit lasting 24 hours or more. I will tell you that that's about to be changed. A TIA definition is a focal, neurologic, non-convulsive deficit lasting less than 24 hours. In reality, most TIAs only last a few minutes. Okay? That's why that definition is about to be changed. There is a paper currently being written. In the neurology world, we've worried about that definition for a long, long time because in reality, most TIAs last minutes, maybe under 5 minutes. Okay? And so in order to get patients to really recognize what's happening and clinicians to really recognize what's happening, there's going to be a paper published that will redefine what a TIA is. Is that what you were looking for?
Well, TIA is the short
Yes.
term. Okay, what about the ones that were longer, like you're talking about, like the loss of speech, the slur? That's not a TIA, right?
Could be,
Okay.
absolutely. A TIA is a transient ischemic attack. In other words, they have the symptoms of stroke, but they return to normal.
No lasting damage, no lasting effect.
Usually not.
Okay.
Usually not. With a TIA, there's usually not lasting damage. Now, we don't know that for sure because in some series where they've looked at TIA patients using magnetic resonance imaging, or MRI, that's very, very sensitive to detecting ischemic changes in the brain. There have been some series that have actually shown that patients with TIA do have some residual neuron loss, brain cell loss, but they may not have the lasting effects of the true deficit, okay? Now, I know that that sounds complicated. That's the best way that I can explain it to you. So we don't know for sure if those patients are perfectly normal, okay? The message, though, is that if a patient has a transient ischemic attack, do not ignore it. Patients should never ignore it. If you have symptoms, call 911. I recommend that patients dial 911. There is a movement also to encourage patients to be hospitalized for a TIA, even though the symptoms may go away. We want them worked up with a stroke workup, like a carotid ultrasound, maybe an MRI, MRA, to take a look at these carotid arteries to see if they're blocked or not, okay? The carotid arteries are very likely, they're a big source of stroke, okay? Especially, and we're going to get to that. I'm going to show you some angiographic information showing you what a blocked carotid artery looks like. Yes, ma'am?
Well, is that the best way to tell me? Because you hear people being perfectly healthy, great blood pressure, everything, and then all of a sudden, you know, is this the best way to measure it? Is by checking the carotid artery?
Not, well,
Is there any blockage there?
now there's a wonderful, wonderful debate. So the question is, should everybody have their carotid arteries checked? That's a debate. I'm not sure that I can answer that for you without getting into a political issue that I don't want to get into. I think the most important thing is for patients to stop smoking, control their blood pressure, control their diabetes. If you do that, you're going to avoid atherosclerotic vessel disease, okay? But yeah, that's a place I'd rather not go, because that becomes then, you know, that's been hotly debated. Because there are those screening opportunities in the mall for people to, you know, companies to do your carotid arteries and that kind of thing.
Well, I
And
guess my question is just like, for people who don't have the smoking, or don't have the diabetes, don't smoke, all that, and then, you know, what else can you do, just to double check?
keep practicing prevention. Her question is, if you don't smoke, you don't have high blood pressure. If you don't smoke, you don't have high blood pressure, you don't have diabetes, you don't abuse alcohol, you don't abuse drugs, cocaine being a cause of stroke, your chances of stroke are less. Okay, it's those people that have risk factors for stroke that are the ones that are more likely going to have strokes. Now, can we say that people like you and I that are perfectly healthy don't have strokes? We do, unfortunately. We can't control everything. Some of it is our destiny, it's our genetic makeup, it may be our racial or ethnic background, we just don't know that. But what we should do is practice prevention, just like you try to prevent cancer by not going in the sun, or you try to prevent heart disease by exercising your heart. You know, all those things we have to do. Unfortunately, there's a play of chance in who we are genetically. We can't control our genes. Does that help? Okay, good, 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 good. All right, so 15% of all strokes are heralded by a TIA. Many patients don't know it though. In other words, they may have a transient focal non-convulsive neurologic deficit, may last a couple of minutes. They're in the shower, they're lathering up, all of a sudden somebody drops the bar of soap. Can't figure out why. But within a couple of minutes, they return to normal and they think, oh, this is great. Must have just been something that happened. And then they go on within a short amount of time to go ahead and have a full-blown stroke because they've ignored the symptom. It's very, very difficult. And to try to teach patients that that's an emergency is really difficult, especially when they go back to normal, okay? After TIA, the 90-day risk of stroke is 3% to 17%. It depends on the series, and is highest within the first 30 days. So that's why we really encourage patients to seek help. What is the treatment if somebody has a TIA? First of all, they get worked up, they get a stroke workup, they get a carotid ultrasound, you know, lots of imaging to make sure there's no blockage here, and they get put on an antiplatelet medicine such as aspirin, plain old aspirin. Okay, let's get through these. It's not working. There it is, and it's probably going to change. So I think I've probably driven home the fact that TIA is a very important risk factor for stroke. I see a question back there.
The TIA is not going to show any lasting effects on a CT or anything like that. Do you just do those, you just do preventatively based on the history the patient gave you, or is that so you just kind of do it anyway?
The stroke workup would be the same for stroke or a TIA, okay? And I didn't include that in this presentation, I probably should have. Generally, patients are admitted, they get lab work, CBC, chemistries, PT-INR, urinalysis, you know, because infection, there has been a relationship between infection and the development of TIA or stroke. They get a CT scan of the head, usually an MRI with MRA to rule out any carotid artery disease, okay, or other small vessel disease. They get sometimes a duplex ultrasound, okay. They may get an echocardiogram, okay, ruling out heart disease, because heart disease can also cause stroke. The number one cause of cardioembolic stroke for the doctors in the room, atrial fibrillation, non-valvular atrial fibrillation. It's an irregular heartbeat, and most common heart dysrhythmia in patients over 65. Am I answering your question?
Well, I think so. So even if, so the patient comes in and we do the scans and nothing shows up on there, we're gonna go ahead and do those things.
Absolutely.
And then they leave just off the history.
Absolutely, absolutely. You're gonna get a neurologic consult, very, very important. You're gonna check, make sure the patient doesn't have diabetes, make sure that diabetes is not being the stroke or TIA mimic, okay? High blood sugar or very low blood sugar can be what's called a stroke mimic and can cause symptoms of stroke. Migraine headache, severe migraine headache can also cause symptoms of stroke. Am I answering, getting
Yes,
closer
yes.
to?
Yeah.
Yes, ma'am.
Are there lab tests that can detect TIA?
No. Labs, she asked, are there lab tests that can detect TIA or stroke? Generally not. Now, there are some patients that may have a genetic condition, and they're called, which causes them to be hypercoagulable. In other words, their blood clots more, maybe than it's supposed to. Those are patients that have they're more rare conditions. They're not generally done, in the community. They're very expensive tests to be done. And usually those are reserved for patients that have a stroke, and you're trying to figure out what the cause is. Okay? Okay. Let's see here. We talked about that. I like this right here, and I want to point this out to you. Claiborne Johnston and Associates tried to come up with a predictive model to determine who the patients were that were likely to go on to have a stroke, or that should be hospitalized, okay? Because it's been debated in the medical world, do we hospitalize a patient with TIA? And so it's kind of interesting for neurologists especially, and emergency room physicians, to understand, should we hospitalize this patient or not? So Claiborne Johnson and his group came up with these predictors of possible stroke in patients that come in with a TIA. And what they found were basically 5 predictors, okay? If the patient was older than 60 years old, if they have diabetes, if they have focal symptoms of motor weakness, in other words, paralysis or paresis, if they have some kind of speech impairment, and if they had a TIA lasting longer than 10 minutes, okay? Those were highly predictive of patients that would go on to have a stroke. The reason why they did this is because, again, it's been debated in the community, do we admit a TIA patient to the hospital? I would argue it's probably a good thing to do from my clinician, my nurse clinician point of view of 20 years of working with stroke patients. Why? Because I know that if a patient has a stroke in the hospital and my hospital gives TPA, tissue plasminogen activator, I can get to that patient very quickly with treatment. Okay, so logically speaking, it kind of makes sense to me as a clinician. Okay? I'm wondering if I'm supposed to be, should I be?
You're okay, let's go.
Okay, okay, good. So clinical research trials, I'm jumping around, trying to give you a broad overview, just stroke, but I'm also doing a little bit of teaching in the middle, okay? A lot of clinical research trials going on out there. Clinical research is the only way that we can move forward in understanding how we can treat and maybe even cure a stroke. At this point, there's really no cure for a stroke, okay? There's one proven therapy that we can give within 3 hours if the patient gets to us quick enough. Then the rest is good clinical care in the hospital as well as good prevention, which is up to us as clinicians to do that. Okay? So prevention, several ongoing trials looking at different prevention strategies. Many are NIH funded and some are industry funded, that is by a drug company. Okay, so what's new in prevention? Just to let you know, for many years we knew that high cholesterol was directly related to the development of coronary artery disease. And we knew that if we treated patients with drugs to reduce cholesterol, that we could prevent heart attack. But we didn't know that in stroke until the Sparkle study. The Sparkle study was a 5-year clinical trial that compared atorvastatin, and the brand name is Lipitor, with, placebo in patients that had had a TIA or stroke. Patients were randomized. It was a multi-center, randomized, controlled, placebo-controlled trial. They randomized 50% of the patients to atorvastatin, high dose, 80 milligrams, or placebo. In other words, nothing, because at that point we didn't know. Well, I say placebo. The patients got a placebo, but the clinicians, such as myself, because I was a research nurse here in San Antonio for this study, we really encourage patients. We did a lot of patient teaching and really tried to encourage them to reduce the risk of stroke, to eat a low-fat diet, control their blood pressure, control their diabetes, get exercise, all those good things. So it was kind of placebo control. We used lifestyle modification in this particular study. It was the first large randomized trial, lots of patients in this study. The endpoint was recurrent stroke or TIA. That was the primary endpoint. And basically what they found was that atorvastatin, the patients that took atorvastatin had a 16% risk reduction of recurrent stroke or TIA during the 5-year period of follow-up, which was a nice long period of follow-up. Okay? So now if patients have stroke or TIA, they have hyperlipidemia, it's now recommended that they take some kind of lipid-lowering agent to reduce their cholesterol. We also know that statins, we know that these drugs have an effect on the lining of blood vessels, and it's kind of an anti-inflammatory effect. And so it kind of makes sense that it would decrease the thickening, if you will, of these blood vessels that could lead to stroke. Okay? What else is new in stroke? About 1.5 years ago, the FDA approved this device. It's called a clot retrieval device, or the Mercy device. It's used primarily in patients where you can actually see a blood clot in one of the larger arteries of the brain, either the middle cerebral artery, and in some situations vertebrobasilar or posterior circulation. The FDA approved it in treating patients with large strokes within an 8-hour time frame. And basically this is similar to what the cardiologists are doing. In a sense, it's a catheterization procedure. The catheter is threaded up through a major artery into the brain. It connects with the clot, and very gently this clot is removed from cerebral circulation, restoring circulation to the brain. This is what it looks like. This is it's a little spring, cone-shaped spring apparatus that's deployed through the clot, connected, kind of grabs onto it, and then it's pulled out. Here's an angiogram kind of showing you the little clot up here, there's the balloon, and what's going to happen is that the endovascular doctor is going to pull this out, this clot out of cerebral circulation. Okay? Which sounds a little bit weird, but actually the safety of the device was approved by the FDA. Efficacy is still out there, but we're getting a little closer to finding modalities that may be helpful for our stroke patients. Ongoing clinical trials of interest. I talked to you about carotid artery disease. We'll talk a little bit about the COST study. That's carotid occlusion surgery study. It's sponsored by the National Institutes of Health. The SPS3 study, secondary prevention of small subcortical strokes. These, which actually we'll talk a little bit about that. The SPS3 study coordinating center is here in San Antonio, here at the University of Texas Health Science Center. It is a multinational study to look at strokes, and especially in the Hispanic population, or the Latin Mexican American population. The PROFESS study is the largest secondary prevention study of its kind. It's 2x2, well, we're going to talk about it in just a minute. let me go on to the IRIS study. This is really cool. Insulin resistance intervention after stroke. This is NIH funded. This is cool because this is looking at patients with pre-diabetic state, okay, with insulin resistance, and prevention of stroke in those patients that are found to be insulin resistant. Have you all heard of insulin resistance and metabolic syndrome? Okay, very important. Precursor to diabetes, to the development of diabetes, okay? And then the CREST study, carotid stenting. You all may have heard of stents in coronary disease, in heart disease. Now we're looking at stents in what? Carotid artery disease, okay? So, here's a patient with a left internal carotid artery occlusion, right carotid artery, left carotid artery, major important blood flow to your brain, that the carotid arteries provide the most blood to your brain. And you can see right about here, this patient has no carotid artery, okay? It's been blocked off. There's a stump there. Okay, that means that patient's not getting any blood to their left hemisphere. Okay, so the carotid occlusion surgery study is looking at when patients have a complete carotid artery blockage, there's really nothing you can do. When it's blocked, it's blocked. So I'm urging you guys, do not eat at McDonald's. Watch the fats, because that's what causes, is a precursor. High-fat diet is a precursor to the development of carotid artery disease. Okay. By high-fat, what do I mean? What foods am I talking about? Just to make sure we're on the same page. French fries. Absolutely. What else? Pastries, cookies, fried chicken, fried fish, pizza, lots of cheese. That's a high-fat diet, and that's what causes blockages in your arteries. Okay? So, the next time you eat your McDonald's Big Mac, and I'm not totally against McDonald's, but the problem is that people eat there every single day. It could be a nice treat. The next time you put that French fry in your mouth, I want you to think of your poor little carotid artery maybe possibly being blocked off in the future. Smokers, if you smoke in here, I'm begging you to quit. Smoking also causes disease of blood vessels. You can be in denial all you want, but it causes disease of blood vessels. To the brain, to the heart, to the legs. It's a drug. Nicotine is a drug. Okay, guys? So if anybody in here smokes, please stop. I'm begging you. I'm not above begging, especially when it comes to smoking. Okay, so the carotid occlusion surgery study is really kind of cool. I was also a part of this. Just recently kind of left this job to come to my new job. It's a trial because there's really no surgery that can be done to unblock a carotid artery. Okay, and there's several medical reasons for that I won't go into. This study is revisiting a procedure called the extracranial to intracranial bypass. So in other words, what happens is patient has a completely occluded artery. Neurosurgeon takes the superficial temporal artery, which is right here. When you put your hand here, you can feel a pulse. And anastomoses that vessel, if it's a good vessel, into the middle cerebral artery of the brain to restore some circulation back to the brain. Okay? This is in clinical trial. It's been very, very slow to get going, mainly because it's a very, very difficult study to recruit patients for. Yes, sir?
Has it had some bad results with the
No. No, you can't do an endarterectomy on a patient that's completely occluded. If you're completely occluded, you cannot do a carotid endarterectomy. If you're 99% occluded, you can. But if you're completely occluded, you can't. And the reason for that is that plaque, if you remove the plaque, basically what's going to happen is that the vessel's going to fall in on itself. Okay, so you're really not doing any good. So, good question. And I wasn't going to go there just because of one of those. But carotid endarterectomy is a surgery that can be done to the carotid artery if you're, say, 69 to 99% occluded and you're symptomatic. Sorry about that. So anyway, very, very good question. This is actually looking at patients that have complete carotid occlusion. Just remember, the next time you smoke that cigarette or eat that supersized, double-sized, triple-sized French fries, just remember what you're doing to your little carotid artery. SPS3, secondary prevention in small subcortical strokes, being done to look at prevention, how to best prevent these small lacunar strokes from occurring. Very prevalent in our Hispanic population here in San Antonio. Why is that? Why would this type of little stroke be prevalent in our Hispanic population in San Antonio, Texas? Can you guess? What's that? Diabetes. Who said diabetes? You get an A. Diabetes. As you know, our Hispanic population has a very high rate of diabetes. Diabetes causes small vessel disease. Many of these patients also have, what's the #1 risk factor for stroke? Hypertension. Diabetes and hypertension, not a good combination. Causes these small little subcortical strokes. They're tiny little strokes. See that little dot there? And that little thing there, those little divots? Those are small strokes, okay? Patients that have diabetes and high blood pressure develop these small little, they're called lacunar infarcts. What ends up happening is that if you get enough of these, you're going to have paralysis, speech problems, you're going to have several different neurologic deficits, but also what you're going to end up having is cognitive difficulty. You're not going to think correctly, okay? Now, what happens when you cannot do those things? You can't work anymore. So many times in our African American and Hispanic population, they have a predilection to this, and it actually happens at a younger age in the 50s, okay? So unfortunately, these folks, you know, may be disabled, they can't go to work, they can't provide for their families, it becomes a major problem. So we're looking at ways to prevent. Obviously, treatment of diabetes is going to be a big one. Control of diabetes and hypertension. Okay? The PROFESS study, again, largest secondary prevention trial of its kind in the world. I was actually a part of this as well. Over 20,000 patients were randomized to this study worldwide. It's comparing antiplatelet therapy with also another drug called an ARB, an angiotensin receptor blocker, to reduce the risk of second stroke. Okay, it is sponsored by a drug company. It is comparing Agrinox with clopidogrel, which is another antiplatelet agent. Okay, and the primary endpoint is recurrent stroke. So there is research going on to see how we can better treat patients. This is the cool study, another cool study, the IRIS study. Again, we talked about this insulin resistant being a pre-diabetic state that could potentially cause stroke. Many patients are walking around, many of us, in fact, many of us in this room, may end up developing what's called insulin resistance, especially if you have a family history of diabetes or, you know, whatever. Anyway, this study is really, really cool. It was really fun to be a part of this study while I was here at the university. Planned follow-up is 4 years. They're going to randomize over 2,000 patients. Prior studies before this big NIH-funded study. Does anybody know what the NIH is? National Institutes of Health. I gave a talk to a group of people not long ago, and many people in the audience didn't know what the NIH was, and I thought, man, that's our premier health organization in the United States. Does anybody know what the AHA is? American Heart Association. A lot of people didn't know what that was either. So anyway, okay, so another education piece. So anyway, we'll be waiting to see what happens here. In this study, they're taking a drug for diabetes called pioglitazone, comparing 45 milligrams, comparing it to placebo. Patients are randomized. They don't know what they're taking. They take a pill every day, and they're followed for 4 years. And basically, what we're going to see is, you know, who does better. And we'll know at that point in time if we have a definitive treatment. We'll also understand whether or not we can predict those patients that will best benefit by this type of treatment if they have insulin resistance. Okay. The CREST study, again, remember I talked a little bit about stents in the carotid artery? Well, in cardiology we know that stents work. We know that it opens up blood vessels. In the brain, though, I mean, a lot of neurologists are wondering whether or not we really want to have something metal in our carotid artery, the major artery that goes up to our brain. And so before anything gets to human use, you know, in the future, it has to go through research. So we're looking to see whether or not, or they are looking to see whether or not stenting is good to prevent stroke. Okay, and these are patients that have stroke. And I don't remember, TIAs may also be included in the study. I do not remember that. Okay? So again, more research out there. What about intracranial hemorrhage? Remember we talked a little bit about intracranial hemorrhage? And we talked about the major risk factor for intracranial hemorrhage being what? Hypertension. Yes. Who said that? Somebody said that. She said that. Okay, good. We know now, well, basically, we've had no treatment for intracranial hemorrhage. Patient comes in, this is a CT scan of a patient that has a very large, lobar intracranial hemorrhage. I mean, that's big. That's a big hemorrhage. There's midline shift there. There's cerebral edema around the area of hemorrhage. On a CT scan, just to orient you guys, this is an X-ray of the brain. For those of you who don't know, this is bone here. This is blood. You're not supposed to have blood like this in the big old blood clot in your brain, okay? A couple of studies, the Stitch trial proved a couple of years ago that surgery was not better than medical conservative treatment, okay? Because what happened? So then medical modality. So then the FAST trial looked at giving factor 7A, which is an basically it stops hemorrhaging. It's given to hemophiliacs. Looked at giving factor 7A to patients that had an intracranial hemorrhage, within 3 hours after stroke symptoms onset. And basically it showed the factor 7A actually did not reduce the risk of death, disability. Okay, so unfortunately we still have no good treatment except for prevention of patients with intracranial hemorrhage. Intraventricular hemorrhage is another horrible thing that could happen to patients, again, caused by trauma, maybe hemorrhage. That is blood in the ventricles of the brain that's not supposed to be there. That can end up causing hydrocephalus, cause brain edema, can cause patients to die. The mortality rate for this is very, very high. So there's an ongoing trial called the CLEAR IVH study where an intraventricular catheter, if it's placed in the ventricles to drain the blood, doctors in this study are administering small doses of tissue plasminogen activator, which is a clot busting drug, to basically encourage quicker draining of the ventricles to get the blood out, okay, to prevent hydrocephalus and some of those other things that can cause death. Follow-up for these patients is 6 months. There's another trial going on called the ANCROG trial. I don't know if any of you all have heard of the snake venom treatment. The Malayan pit viper has a venom that causes patients to basically be hypocoagulable, causes the blood to be thinner, if you will. That's the best way to describe it. Anyway, they're looking at this treatment out to 6 hours. So our friends in the nature world can provide many drugs, many chemicals that may help in the treatment of certain problems. Okay? Craniectomy, this is also new in stroke. For many, many years there was debate about whether or not to do a hemicraniectomy in patients that had very large strokes. Very large strokes can cause increased pressure within the skull on the brain, can cause patients to basically what we call herniate and then die. And so there's been debate on there whether or not you should remove the skull, part of the skull, a window of the bone here, to relieve the pressure in the brain, okay? a couple of trials, and this shows you a CT scan showing a piece of bone that was missing, but look at the size of this stroke. I mean, that's a whole hemisphere essentially. So there were two trials, the DESTINY study, the decimal study, Destiny, decimal. And basically what these studies both showed is that with pooled analysis, we know that if you just manage these patients conservatively with no removal of bone, there's an 80% mortality. When the data were pooled from the DESTINY and decimal studies, they found that it reduced mortality significantly. The issues are, though, to what degree is still in debate. Quality of life, you may save a life, but what is the quality of life after you save it? We about done? Okay. But what is the quality of life after you save it? So we are expecting to have the results there pretty soon. National Stroke Advocacy, I'm going to go through these slides very quickly because time is up. Basically, there are several national movements and initiatives for stroke advocacy. There are stroke laws being implemented nationally and on the statewide. We also have Medicare, there are several Medicare caps for rehab. We are now lobbying in advocacy to release those caps so that our patients, as you remember, the cost of stroke is very high. We need better reimbursement for better care. We're thinking that better reimbursement might actually prove to be better care. There are new American Heart Association, American Stroke guidelines out there. I would really urge you to go to the American Heart Association website, find their current scientific statements, use them in your practice. Okay, you can also educate your patients by looking at those guidelines. There are recommendations for the establishment of stroke systems of care, and we're going to talk about that in the state of Texas. In Texas, in 2005, and I'm proud to say that I worked on this initiative, we passed a law stating that basically we have to have stroke systems of care in the state of Texas. It will be very similar to the trauma systems of care here. A GTAC, the Governor's Emergency Trauma Advisory Committee, was appointed at that time. We've been working now for a year. It's a very active, wonderful. In a year, we've put together stroke systems of care plans for EMS, as well as what hospitals can call themselves stroke centers. Okay? We want patients transferred to stroke centers. Stroke centers will be those hospitals that can deliver the care that's been proven to be effective for stroke patients. Okay? I'm going to go through that. There is a certification for stroke centers. This was happening even before what was going on here in Texas. The Joint Commission came up with a disease-specific certification, and that is leading to hospitals around the country becoming certified as stroke centers. In order to do that, you have to at least be able to prove that you are able to do 10 basic things. Okay? These are called performance measures. You're going to consider TPA if a patient comes in within 3 hours. TPA is tissue plasminogen activator, the only proven therapy for stroke. You're going to give aspirin to patients within 48 hours to prevent another stroke. You're going to make sure they're discharged on aspirin. You're going to give Coumadin to patients that have atrial fibrillation, because anticoagulation is the most proven therapy for prevention of stroke in patients with AFib. You're going to do a lipid profile. You're going to screen for dysphagia or swallowing difficulty, because you don't want your patients to aspirate, okay? You're going to consider rehabilitation. You're going to prevent deep venous thrombosis in legs, blood clots in the legs. You're going to encourage patients to what have we talked about today? Stop smoking! And you're going to do patient stroke and family education, okay? All right. Stroke units, very, very important. You're going to see the popping up of more stroke units, okay? These are like critical care units, ICUs. Why not have them for stroke patients? You're going to have specialized medical personnel taking care of these patients. Tissue plasminogen activator, the only proven drug to be given to acute ischemic stroke patients within 3 hours. still underutilized, mainly because many physicians out there that still don't believe in it, which is a shame because they're not giving the patients the chance to be treated. And also patient awareness. Patients don't get to the hospital, they don't recognize the signs and symptoms of stroke within that. Okay? Other quality improvement initiatives, many going on. Get with the guidelines as an American Heart Association program for quality improvement. I know you guys have talked about that. The Coverdale Stroke Registry, this is the CDC's stroke registry. And that's it, guys. I'm sorry I went over time. Are there any questions? I know I wasn't quite sure what level